Prerequisite: uh, patient fitness for general anesthesia. Patient coagulation profile should be normal, so this is very important that coagulation profile should be normal. Systemic antibiotic should be administered. Counseling of the patient. Informed written consent should be taken. Overnight fasting. Pre-anesthetic checkup. Screening. HBsAg. Consent for operation if necessary. Procedure: IV situation for patient using a side viewing endoscope at the ampulla of water can be identified and cannulated. Injection of the water soluble contrast directly into the bile duct provide excellent image of the ductal anatomy. Can identify cause of the obstruction such as stone or malignant strictures. Indication: there are some diagnostic indication and therapeutic indication. Diagnostic indication includes the pancreatic disease, neoplastic inflammatory obstructive jaundice, choledocholithiasis, cholangiocarcinoma, bile duct stricture, bile duct injury, collection of the bile for microbiological culture, brush cytology. Therapeutic: sphincterotomy for papillary stenosis, stone extraction, biliary stone, lithotripsy. So we can perform sphincterotomy. So here is the sphincter. We can perform sphincterotomy. We can remove or extraction of the stones. And we can biliary lithotripsy. In the biliary, we can perform lithotripsy. Here biliary gel, and if there is a stone, we can go and perform lithotripsy. It is the tube. There is lithotripsy. Okay, there dilatation of the biliary stricture. So if there is biliary stricture, we can go for biliary stricture there, then we can go for dilatation. Now come to the point, what are the contraindication? The absolute contraindication is gastric outlet obstruction and polygastrectomy, and relative bleeding disorder and pancreatitis. Complication: there are several kind of complication. We can differentiate it by early and by late complication. Early complication includes early bile duct perforation, minor bleeding from the sphincterotomy or lithotripsy, cholangitis, acute pancreatitis, bacteremia, ruptured hematoma, and duodenal perforation. So it is very important. Bile duct could be perforated, minor bleeding from the sphincterotomy. There may be chance of cholangitis, acute pancreatitis, bacteremia, ruptured hepatoma, and duodenal perforation. Late surgical emphysema, retroperitoneal abscess, septicemia. Risk factor for post-ERCP pancreatitis: definite. Suspected sphincter of OT dysfunction, young age, normal bilirubin, prior ERCP related pancreatitis, difficult cannulation, pancreatic duct, contrast injection, pancreatic sphincterotomy, balloon dilatation of biliary sphincter. Possible female sex, low volume ERCP performed, absent CBD stone. Advantages: both diagnostic and therapeutic can be done in same sitting. Biopsies can be taken. Disadvantage: invasive procedure or preparation of operation before doing ERCP. Limited availability, expertise needed, expensive, serious complication may arise. So conclusion is widespread availability of the ultrasound and MRCP has limited the diagnostic use of ERCP, so it has evolved nowadays into a mainly therapeutic rather than a diagnostic technique. Thank you. Thank you all. Now another question is MRCP. It is very convenient. ERCP MRCP runs side by side. That the MRCP stands for magnetic resonance cholangiopancreatography. is an imaging technique based on the principles of the nuclear magnetic resonance. So, on the principles of the nuclear magnetic resonance used to image the gallbladder and biliary system. So, this is very important speaking or important ukti or important quotation that the nuclear magnetic resonance used to image the gallbladder and biliary system. Now, principles of MRCP based on heavily weighted T2 pulse sequence. So this is the first principle. The MRCP includes the heavily weighted T2 pulse sequence. So this line is most important line in this whole question, that it is heavily weighted T2 pulse sequence. Now very high signal comes from the bile and pancreatic juice along T2 relaxation time. When there is T2 relaxation time, very high frequency comes from the pancreatic juice and the bile. The hyperintense signal comes from the bile column against hypointense liver tissue. So indication, biliary stones, 2 millimeter stones can be detected. So size of the stone is very important. It is 2 millimeter. Colorectal cyst can be detected. So here there is colorectal cyst which can be detected, and bile duct injury. If there is injury, in the bile duct, it is known as PDI, outline of the duct and peripheral duct collection. Bile duct tumor. If there is a tumor in the bile duct, pancreatic disease, pancreatic divisum, chronic pancreatitis, ampullary tumor, carcinoma, body and neck of the pancreas. Contraindication. Absolute contraindication: ocular metallic foreign body, pacemaker, cochlear implant, cranial aneurysmal clip. What are the absolute contribution? Ocular metallic foreign body. If patient have ocular metallic foreign body, he should not go for MRCP, as there is a magnetic resonance which could pull out the iron or metallic foreign body that could damage the eye. And if there is pacemaker, it could hinder the function of pacemaker, even it could ripped off from his body. And cochlear implant, it is same, occurs in the same way. And cranial aneurysmal clip, if the cranial aneurysmal clip is titanium, not titanium, it should be avoided, and it should be kept in mind. Okay, relative contraindication: first trimester pregnancy and claustrophobia. The previous one was absolute contraindication. Now these are the relative contraindication: first trimester pregnancy, claustrophobia. Advantage: non-invasive, can provide either cross-sectional or projection image. Contrast is not so. Here there is some advantage. First of all, this is non-invasive. There is no need for invasiveness to input anything other than just a cannula and contrast media. Can provide either cross-sectional projection images. Contrast is not required. There is very low failure rate because this is totally not operator dependent. It will later on help or adjust it by the setting the image, and no radiation hazard, as this is only magnet, so there is no radiation hazard. Disadvantage: so no therapeutic application, so it could not be done any therapeutic application. Limited availability, it is very expensive, time consuming in comparison to CT scan. CT scan is just one breath hold method, but MRI or MRCP is a time consuming long method. Can distinguish stone from the surgical clips and pneumobilia, hemophilia and clot. Unable to establish whether the bile leak is active or not. Conclusion: MRCP can be done if titanium matte prosthesis is applied, so we should keep this in our mind. Thank you for your patience.